welcome to this webinar where we will be sharing a report on how patents have impeded access to COVID-19 drugs, diagnostics, and vaccines. We're very happy to be able to share this report with you and are looking forward to the discussion we'll have after it's been presented. So the report is the result of a collaboration between a number of organizations, FTPL, Health Justice Initiative, MSF, Section 27, Cancer Alliance, and of course PHM South Africa. It's accompanied by a tracker of COVID-19 vaccines, drugs, and diagnostics, and advocacy on that issue by civil society organizations in South Africa. That will be available at a later date, but we will briefly just share on that in today's webinar. We're happy to be joined by Tomlinson, who is a public health research consultant. She's finalized the in-depth research report on the impact of patents on access to things like PCR tests, molunpiravir, and ritonavir and the mRNA vaccines, also focusing on the impact of the Moderna patent on the effectiveness of the hub. We'll also be joined by Lauren Paremoer, who is a lecturer at BCT and a steering committee member at PHM, and she will be talking about civil society action addressing the issue of access to these medicines, as well as the gender-specific impact of patent protections. So I'll hand over to Catherine first, and then she'll be followed by Lauren. And then after that, we'll have a discussion on how we can use this report on advocacy going forward. So Catherine.
Hi. Are you able to share my PowerPoint from your screen, or should I try and share screen on my side?
We made you co-host, so you're welcome to share from your side, but if it's easier we do it, I'm also happy to. But I think it's probably easier if you share.
I'm just, is it working? Can you see my, no.
Yes, yes, we can see.
You can see the PowerPoint?
Yes.
Okay, okay. So I am going to speak specifically about what the research found in terms of what patents there are on COVID-19 health technologies and their potential impact on local manufacturing and access in South Africa. So in the research, we looked at Moderna's mRNA COVID vaccine, Pfizer's mRNA COVID vaccine, Cepheid's COVID-19 PCR diagnostic test cartridges, Merck's antiviral molunpiravir, and Pfizer's antiviral medicine Paxlovid. I've also just added some information in the report about, in this PowerPoint about baricitinib, because that was recently recommended by the WHO as a therapeutic for COVID-19. So it was two vaccines, both the mRNA vaccines, one diagnostic, and this was selected because South Africa has invested heavily in this company's diagnostic machinery. And so we have this diagnostic machinery all over the country, but there was a struggle to access enough test cartridges to really fully realize kind of the capacity of the machinery we'd invested in. And then these three therapeutics at the end. So first I'm going to speak about Moderna. So as many of you know, Moderna has pledged not to assert its patents during the pandemic, but it retains discretion of determining when the pandemic ends and when it will begin asserting its patents again. It has also filed a number of patents in South Africa and with very broad protection, so broad that they could have kind of an harmful impact on the introduction of any new mRNA vaccines in South Africa. And as we know, Moderna is facing a number of legal cases with mRNA companies outside of South Africa. But in South Africa, where there isn't examination or opportunity for opposition, the patents have been granted with really no review of their merit to ensure they meet patentability criteria and no opportunity for opposition. Moderna has also So while it has said it won't enforce patents, it's still filing patents, and it's refusing to cooperate with the WHO mRNA technology transfer hub, so to share its technology to enable the development of the vaccine through the WHO mRNA hub. So to date, Moderna has filed 8 patents related to its COVID-19 mRNA vaccine in South Africa, 4 of which have been granted, 3 of which remain pending, 1 of which has been withdrawn. So it would have been drawn at the international level likely, and then withdrawn in South Africa, because these patents would have been filed through the World Intellectual Property Organization's Patent Cooperation Treaty. So there's companies can file through that structure, and then select which countries they will file patents in. So these patents would have been filed in South Africa. So it won't have been withdrawn because there was opposition necessary, or that it had been challenged in South Africa, because we don't currently have procedures to do that. So the impact of the patents granted in South Africa is that it will delay the development of the vaccine through the WHO mRNA hub. So as many of you will know, the WHO mRNA hub has announced that it has successfully developed a trial batch of the mRNA vaccine based on the Moderna vaccine. And so this is excellent news, and they were able to do this with knowledge transfer from other experts around the world that weren't involved with Moderna's patent portfolio and supported the WHO. But there will still be delays in terms of finalizing development of that product and bringing that product to market. For example, because it isn't a technology transfer of an existing vaccine, because they're making a new vaccine based off of the Moderna vaccine, they will be required to go through more extensive clinical trials, which is a very long and expensive and expensive process. The company will also need to develop all of its own operating procedures and quality assurance procedures in order to get the good manufacturing process approvals that it requires to manufacture vaccines. And so Moderna's refusal to transfer technology is going to impact on the timeline of the introduction of the vaccine from the mRNA hub. It also creates significant uncertainty regarding whether the vaccine developed through the mRNA hub can be commercialized in South Africa, because currently the mRNA hub is producing the vaccine under the assertion by Moderna that they won't enforce patents, and also under the BOLA exception, which is an exception within South Africa's law and provided for under international law that allows for the recreation of generic products and development of generic products prior to the end of patent terms. So the Fix Patent Laws campaign has actually called for amendment to South Africa's laws to broaden these exceptions and include a broad research exception, which would provide even more legal certainty for the Moderna mRNA hub to operate. But currently, where we expect that we are is that the mRNA hub can move forward with clinical trials and research and development of its vaccine, but when it moves to commercialization of its vaccine, it will need a license, either a voluntary license from Moderna or compulsory license in order to bring its product to market in South Africa. So while South Africa has done really impressive things in the hub, and Afrigen have been really impressive in terms of being able to reverse engineer Moderna's vaccine and develop it themselves locally, there are still legal barriers to the introduction of the product at commercial levels. So there are a number of things that civil society can do to kind of challenge the patents, the patent monopolies, and the knowledge monopolies that Moderna is holding. It can continue to ramp up pressure on Moderna to license its intellectual property to the hub and to transfer its technology to the hub. Within South Africa, there is likely a need to develop an advocacy and legal strategy to challenge the patents that have been granted to Moderna, and then to continue to advocate for urgent reform of South Africa's patent laws to ease the process of compulsory licensing. So South Africa can issue a compulsory license to overcome the patent monopolies held by Moderna, but currently the compulsory licensing process within South Africa is more difficult than it needs to do, and will likely be challenged in court, and will likely hold up the introduction of a product following its development. And so South Africa can actually amend its laws to make it a much more usable way of ensuring access to important health technologies like the vaccine. So just to go back to so you can see these patents. There's a number of patents that have been filed by Moderna with a broad range of protection, and they're currently lasting through 2032. So unless the patents are overcome through voluntary or compulsory licensing, it could be a barrier to the introduction of a competitive product through 2032 in South Africa, which is very concerning. We also looked at the Pfizer's mRNA vaccine. Pfizer has filed multiple patents on its vaccine related to its vaccine globally through the WIPO's Patent Cooperation Treaty, but it has not yet filed patents in South Africa. However, 2 patents that were recently filed through the WIPO Patent Cooperation Treaty may be filed in South Africa up to the 22nd of October 2022. So this is something for civil society to be aware of and to monitor whether these patents are actually are pursued in South Africa, because that can be blocking, they will be blocking to the introduction of competitive products. But unfortunately, South Africa doesn't have a process for monitoring patents that are applied for in the country to allow for third parties to monitor and oppose patents. And this is something that Fix the Patent Laws has long advocated for. So it's another example of why we need to reform our laws to ensure that patents that are harmful to public health and public interest or do not meet the criteria for patentability are not granted in the country. And while Pfizer has not yet filed patents in South Africa, it has spoken openly about opposing the TRIPS waiver that's been called for South Africa to allow countries not to grant or enforce intellectual property during the pandemic. And it has also refused to cooperate with and share its technology with the WHO mRNA hub. Pfizer has granted a fill and finish license to BioVac, but this does not allow for the actual production of the drug, the active drug substance. And so already South Africa has capacity to fill and finish vaccines. What we need is to develop is the capacity to actually make the vaccines ourselves, and particularly as we've seen how supply shortages have impacted the developing world in Africa. And so Pfizer has refused and has not shared that knowledge, which is knowledge that really would assist and enable South Africa to play a role in expanding supply and ensuring that there's adequate vaccines for Africa and the developing world. And so these are the vaccines that Pfizer has filed on its vaccine. All of these top ones have not been filed in South Africa. The 2 highlighted ones at the bottom are the ones that Pfizer has until October 22nd to file in South Africa. And if they file them, that can give them protection through 2041. One of them is a broad patent that covers the mRNA composition, and the other one relates specifically to packaging and storage. So this is something for civil society to monitor. And as I said, because there isn't a process to enable civil society to monitor whether the patents are filed or through in South Africa, the only option for civil society to do this is to engage with relevant government officials and departments and really ensure that they're monitoring whether these patent applications are coming in, and to highlight then the importance of not granting patents that are harmful to public health and public interest or don't meet the country's patentability criteria. In addition to engaging government to ensure that there is monitoring of these potential patent applications coming in, civil society one advocacy strategy would be to ramp up pressure on Pfizer to license its intellectual property and transfer its technology to the WHO mRNA hub or through the Medicines Patent Pool or the COVID Technology Access Pool, which is another way of sharing knowledge and intellectual property, which was set up by the WHO. And then at the same time, there's a role for civil society to play in continuing to advocate for reform of South Africa's patent laws to strengthen the country's patentability criteria, to ensure that only patents that meet the country's patentability criteria are granted, and to to put protections in to prevent the granting of patents that are harmful to public health and public interest, and also to enable monitoring of patent applications and opposition of patent applications by third parties. Another health technology that I looked at was Cepheid's COVID-19 PCR test cartridges. And so one of the things that we saw from the NHLS in the early days of the pandemic was they spoke openly about South Africa's readiness to ramp up testing, because we'd invested in Cepheid's GeneXpert testing platforms and also Roche's Cobus platforms. But then because of shortages of diagnostic materials, South Africa wasn't able to get enough diagnostic materials. The wealthy countries were buying up all of the diagnostic materials. I mean, vast majority of supply and leaving little for developing countries. That led to large testing shortages and testing backlogs early on in the pandemic, where we saw at one point there was a 9-day turnaround time to get results from COVID testing from the NHLS. So early on in the pandemic, South Africa actually approached Cepheid about seeking a technology transfer to enable local manufacturing of the test cartridges that were in short supply for the platform that's broadly, for their testing platform, which is broadly available throughout South Africa. But the company was not responsive, and so that didn't move forward. And Cepheid, who is the company that owns the GeneXpert platform and owns the intellectual property on it, has used a number of tactics to build its monopoly position and kind of undermine the entry and growth of competitor companies, including designing closed systems. So what this means is the way their systems are designed prevent the use of any other company's diagnostic materials on the systems. So South Africa can only buy the test cartridges that are produced by Cepheid for use on these testing platforms. They've also hoarded knowledge, refused to share knowledge and license IP and transfer technology, as well as filed patents within the country. So identifying the specific patents that are blocking is really challenging for diagnostics. It's more challenging even than therapeutics in general. And this is because there's a vast array of different types of technologies. And so you need a number of specialists to really go and analyze these patents and determine whether they are in fact blocking. And this can be very difficult for competitor companies that want to come into the market to identify whether there will be a potential for a legal infringement and a legal challenge when they introduce a new diagnostic product into the market. And so the types of technologies are the diagnostic assays, the tests themselves, processes, consumables, and machinery can all be all patented within the diagnostic space. There's also a lack of transparency for all health technologies around what patents are granted on specific health technologies, because companies aren't required to put the name in the patent application, the name of the health technology in the patent application or summary. So it makes it really difficult to search and identify relevant patents on a specific health technology. And then there's the added complexity that we see in South Africa, where patents are granted without a examination to ensure that they're actually deserved, that they meet the country's patentability standards. And so that can be quite challenging for competitors who see a patent but don't think it meets the country's patentability standards, and so want to bring a product to market at risk. They need to determine it, because government doesn't take the step of determining whether or not the patents will actually hold up if challenged. So I wasn't able to conduct a kind of a detailed review of which patents are exactly related to COVID-19, to Cepheid's COVID-19 test cartridges, but I did identify 16 patents that have been applied for by Cepheid related to its diagnostic technologies in general in South Africa. So it is seeking intellectual property protection and using that as a way to kind of protect and maintain its monopoly in the country. So some of the advocacy approaches that civil society can use to try and address these monopolies is to push Cepheid to license its intellectual property and transfer technology to other diagnostic manufacturers, particularly in developing countries, to engage global stakeholders and conduct further research on the need and feasibility for financing and developing open systems, so systems that aren't closed like Cepheid systems, but have the same advantages of Cepheid systems, in that they're automated, they're easy to use, they can rapidly conduct diagnosis on multiple specimens and can be used near point of care. And so we haven't really seen that in the diagnostic space, where kind of another competitor, an open system without intellectual property protections has come in and brought a competitor company and another competitor product. And one of the ways that they are kind of shut off from doing that is that companies like Roche and Cepheid will often lease their machines, so they won't require government to pay the full cost of machines, but they will make their earnings through the ongoing sale of consumables and test materials. So it means that in order for governments to get the open machines, they would likely face a much larger upfront cost. And so that can be a disincentive to investing in open diagnostic systems. So this is a big, difficult space that requires kind of a lot of long-term engagement and thinking, is how to kind of address some of these massive monopolies that we see in the diagnostic space. And then also within South Africa, there have been a number of efforts towards starting to develop developing diagnostic manufacturing capacity, but our manufacturing capacity in the space is still very small. And so further engagement around how this capacity can be further developed and how to ensure the capacity is sustainable is an area to look at. So in therapeutics, I looked at molnupiravir. I'm going to just say Paxlovid, which is the brand name for this one, and then baricitinib. I didn't do as much analysis of that, but I've just added it on because of the recent recommendations by the World Health Organization for that medicine for COVID-19. I understand that there will be a number of opposing views on the value of these different therapeutics, and so I'm not really giving an opinion on the value of these therapeutics. I'm rather just highlighting where patent barriers to access exist for them. So molnupiravir, there have been 2 patents that have been filed in South Africa lasting through 2038. Paxlovid, there's been 1 patent that's been filed in South Africa lasting through 2041. And baricitinib, there's 1 patent lasting through 2029. But for both molnupiravir and Paxlovid, medicine patent pools licenses have been granted that enable access to generic products in South Africa's public sector. And 27 companies, we don't know which companies yet, unless there's been a recent announcement, we don't know which companies yet have been licensed to produce generic versions of Paxlovid, but 27 companies have been licensed to produce generic versions of molnupiravir, and 2 of them are in South Africa, including Aspen and CPT Pharma. Aspen will produce the finished product, and CPT Pharma will produce active ingredients. But there's still no legal pathway for sale of generic products in the private sector. And that may, in fact, disincentivize Aspen and CPT Pharma from actually investing in developing this manufacturing capacity. So there is still room to push for licenses to enable the sale of generic products in the private sector, particularly from these South African producers that will be able to be producing them, but currently aren't allowed to sell them to the private sector. And to ensure that they have a sustainable market to sell to. Another challenge with the MPP licenses is that a number of other lower middle income countries were excluded from the deal, including many countries in Latin America and small island developing nations. So there's still a number of countries that don't have access to generic products through the deals that have been announced. So some civil society recommendations in order to overcome the patent monopolies on these medicines is to push for licensing deals to allow for the sale of generic products in South Africa's private sector, especially by generic manufacturers that are approved to produce them in the country, to push for generic use licensing deals in the developing countries excluded from the MPP licensing deal, and to support efforts to advocate for compulsory licensing in developing countries excluded from the deal. Thank you very much. That's the end of my slides.
Hi, good morning, everyone. And I am going to take over from Catherine. Let's see. I'm just sharing my slideshow. If you could indicate. Okay. Are you able to see the slideshow?
Yes, thank you, Lauren.
Okay, great. So My Baone mentioned at the beginning that my slideshow will focus on two things. One is the impact of these C19 COVID-19 technologies on women, more specifically the inability to access them. And one of the big barriers to accessing them is intellectual property rights. And I think Catherine's presentation illustrated that, and then also to mention some of the civil society actions that have been taken. So, you know, I think one starting point is the assumption of this part of the project is that intellectual property rights seem gender neutral, but they're really not. So this is in terms of their impact, but also in terms of their allocation. So globally, we know that most IP rights that are awarded to either men as individual patent holders or predominantly or all male teams, research teams. There's also research to suggest in the US, for example, Yale did research on the allocation of patents to men versus women, and they found that when researchers with obviously female names file patent applications, they're less likely to be awarded those applications. They're subjected to a higher degree of scrutiny. So that's on the side of allocating patent rights. But what we've also seen in this pandemic is that the impact of these patent rights really affect women's lives negatively in a very practical way. So one of the things I think that's most illustrative of that is the impact that these barriers to accessing COVID-19 vaccines have had on the lives of women health workers. So globally, and the picture in the middle is a reference to a report that PHM did on the impact of the pandemic on women health workers. So some of that is referenced here, but some of what I'm saying also comes from the report that Catherine led on. So globally, we've seen that women health workers or health workers in general are celebrated, but that their demands, their labor demands, their rights as workers aren't necessarily recognized. Most of the workers at the lower end of the occupational hierarchy, so I'm talking about nurses, porters, cleaners, people that prepare food in hospitals, and community health workers. Most of those workers are women. And so particularly in terms of the lower levels of the occupational hierarchy, these women have been constrained in terms of their ability to negotiate things like time off, to negotiate access to PPE. In South Africa, that's been an issue that community health workers have repeatedly flagged. And so even though they're celebrated publicly, these workers haven't seen in South Africa and globally an increase in their wages or an improvement in their terms of work. And in fact, what we've seen is that community health workers in South Africa, for example, have had increased working hours and a continuation of the precarity that has informed their work. On the African continent, vaccine apartheid continues to affect frontline health workers. So I think the most recent statistic is that only 1 in 4 frontline health workers have been fully vaccinated on the continent. And again, that means that most likely it's the nurses, the community health workers that remain vulnerable to contracting COVID-19. And then I think the other thing that's important to note is that this dynamic around increasing burdens of labor at the work site, whether it's the hospital or the clinic or in the community, intersects with patriarchal norms around childcare, for example. It also intersects with things like lockdowns closing schools, or people not necessarily, women in particular, not necessarily being able to access the COVID-19 grant because they already receive other grants. And this has meant that women health workers have not only faced increasing labor time at work, but also that their labor time in terms of the obligations they have to care for children, that has increased during the pandemic. In terms of impact on paid work versus unpaid work, I think many people are familiar with some of the dynamics on the slide. It was part of the NIDS-CRAM study. And several waves of that study indicate that during the early part of the pandemic, women were most severely affected by job losses. So 2/3 of all job losses were suffered by women. But later waves of the NIDS-CRAM study also shows that in terms of a recovery of both jobs and working hours, that women more so than men saw a slower recovery in a return to employment and a slower return to the number of working hours they had worked before the pandemic. And then in addition to that, research by Saldru at UCT shows that women workers tend to be positioned in occupations where it's public facing. So occupations like, if you're a packer or a cashier at a supermarket, these are occupations where you're constantly engaging with people. There's a lot of contact, there's often talking. And it's also, again, a position that's fairly low down in the occupational hierarchy. And both of these things put women at increased risk of contracting COVID at work. So obviously, in terms of being public facing, you can't isolate. That exposes you to more people and more risk of contracting COVID. But also in terms of being at a lower level in the occupational hierarchy, maybe you're not unionized. That means you can't negotiate for time off when you're sick. It also means that you can't negotiate for PPE and so forth. And so in that sense, when women aren't vaccinated, they are at an increased risk of contracting COVID-19. But then in addition to that, as we all know, women have seen their unpaid working hours increase at home. They've had an increased burden of taking care of sick people because the pandemic has increased the burden of illness in the community. And also that in terms of the social reproduction work they do around securing food, that has been incredibly difficult. And we see heightened levels of hunger amongst female versus male household members. And that's because many women, one, have been hard hit by the economic impact of COVID. So there's been a loss of income, but also because of gender roles about who should do the caring and who should take care of children in particular, who should prepare food and so forth. The pandemic has translated into higher levels of hunger amongst women. And then, of course, as I mentioned before, again, because of these patriarchal gender norms, many women have been registered as the primary caregiver of children. It means often they are the ones that are registered as the recipient of things like childcare grants. And so what we've seen, as we all know, is that they therefore were unable to access the COVID special grant, even though they still retain responsibility for the bulk of care work in the household during the pandemic, and particularly during lockdowns. So all of this has had an impact on women's access to healthcare services. What we see is that maternal mortality rates have increased. Some studies show by as much as 30% during the pandemic. Vaccination rates have dropped nationally from about 82% to 61%, and that's during the first year of the pandemic. I wasn't able to find data for the second year. And then also other routine services like HIV/AIDS, test and treat services have been disrupted. And this is concerning from a gender point of view because women are overrepresented amongst the population of people living with AIDS, and in particular, young women. So in the 15 to 24 age group, HIV prevalence is 4 times higher amongst young girls, young women than men. And then, of course, as we know, GBV has increased during the pandemic. So I think, what we need to think about is that all of these dynamics are not disconnected to the IP barriers that Catherine mentioned in her presentation. And in fact, they're very, very entangled with them because to the extent that people don't have access to tests to check their COVID-19 status, to the extent they don't have access to vaccines to prevent getting really, really sick or ending up so sick that you're in hospital and at risk of death. To that extent, people have less mobility, less ability to access income. Children have less ability to enter schooling. And all of these dynamics ultimately affect women more so than men. So very briefly, I think I have 3 slides left. This slide summarizes some of the civil society actions that have already been taken. They include things like open letters, marches, and mobilizations online, so Twitter storms and so forth. And a lot of these activities have been targeted at 3 things. One is trying to push for domestic patent law reform, or even just information about where that process is going, because there's been a big silence from the department, the DTI, around where that process is and whether a new bill will be tabled soon. Of course, we know that that's been promised, but it hasn't happened. The other thing that has been focused on is the TRIPS waiver proposal, which is a global campaign aimed at suspending IP rights on all COVID-19 tests, therapeutics, medicines, and vaccines. And that was something that South Africa proposed alongside India in October 2020. Ironically, it's been very aggressive about this IP suspension at the global level, even though domestically there hasn't been a lot of action on domestic patent law reform. And then the final kind of CSO action, I would say, and this there isn't a lot of information on, but there is collaboration, or there has been collaboration amongst research scientists. And here I'm thinking particularly of the mRNA hub, the WHO hub that Catherine mentioned. And a lot of the work of the hub benefited from scientists, a global community of scientists sharing publicly available data with researchers at the hub, and this facilitated their work. Okay, so some strengths and limitations of CSO actions. One of the things that came out of interviews that Catherine conducted for the report is that there was a feeling that the activism, the civil society mobilization created political space to support tech transfer to the hub. And so that is a good thing. It also increased public awareness around the ways in which IP constrained access to vaccines in South Africa and on the continent. And that's an important conversation. It's a conversation that was most publicly held in relation to HIV/AIDS, but it's since faded over time. And so it's important that that's been given political prominence again. And then another potential positive consequence is that governments on the continent are a bit more skeptical in regarding fill and finish agreements as tech transfer agreements with pharma companies. The hope is that a lot of the mobilization will lead to government officials in South Africa, but also elsewhere, when they negotiate with pharma companies for local production, that this will include the transfer of know-how, of skills, and not just giving local companies the authority to put an already formulated product in a vial and then sell it on. So those are the possible strengths. Some of the limitations: despite a lot of CSO mobilization around domestic patent law reform, there's still silence on this issue. It's not clear where the bill is or when it will be tabled. The TRIPS waiver, which is the global proposal at the World Trade Organization, is still deadlocked. And in fact, one of the things that's concerning at that level is that in an effort to say we'll suspend IP on COVID-19 products, there are attempts to kind of split off different countries. So, for example, one recent proposal is that there should be a waiver on IP, but that India and China, for example, should be excluded from that waiver. And of course, we know that India has a lot of production capacity, so that again will artificially limit supply. There's proposals around only making the waiver apply for a short period of time. And then there are proposals that the waiver should only apply to vaccines, but not to diagnostics, for example. Then some concerns around whether there's too much of a focus on mobilizing in support of mRNA tech transfer, and whether perhaps civil society should also be doing work to support the development of technologies that we do have local capabilities for. So vaccines, for example, that use a protein base, and whether that would be a more strategic use of CSO activism rather than putting all our eggs in the mRNA basket and advocating around that. And of course, one of the reasons for the excitement around mRNA is that the vaccine would be easy to adapt to other diseases like cancer, TB, HIV, AIDS, or relatively easy compared to other vaccines. And so that's why there's a lot of excitement among civil society and scientists about mRNA. But as Catherine mentioned, even though there's advocacy to support suspension of patents on mRNA technology, specifically Moderna and Pfizer's patents, the complication is if those patents aren't suspended, they're so broadly written that it might negatively impact the work being done by the hub, even to the extent that it possibly could impede the use of mRNA technologies, mRNA-based vaccines for other diseases. So that's a big concern. Another thing that perhaps CSOs could focus on is greater support for open science approaches at universities and amongst researchers in South Africa. There's not a lot of advocacy that's been done, for example, to encourage universities to commit to any research that they produce being used in the public interest for the public group, for the public good, and not necessarily automatically patenting that research. So that could be another area of action. And then another thing that maybe has been a blind spot for CSOs is to build knowledge about, or to think about the capabilities of existing institutions to switch to new technologies mid-pandemic. So if we do have tech transfer, or if we do have new technologies that emerge, that might be great for future pandemics. But one of the concerns around the mRNA hub, for example, is if the patents aren't suspended, we might be looking at the vaccines only being available to use in the general population by the end of 2023. And by that time, it might be too late, so to speak, to lead with local vaccines. And excuse me, another concern is around diagnostics or testing. It might be that we're able to develop new technologies, but our institutions that are doing the testing, so public sector institutions, for example, already have a workforce that has expertise in using the existing diagnostics. And so there are questions around when you have to do testing very quickly, is it possible to switch to a whole new testing system, even though it might be cheaper, it might be locally produced, it might be open science-based, but it might not fit with the existing workflow. And so there is a question around whether civil society needs to think about how to incorporate those constraints in their advocacy. So yeah, that's me. And I'm going to hand over to Baone now for the question and answer session. Thank you.
Thanks so much, Lauren. And thank you as well to Catherine. Those were some really insightful presentations. I think they've given us some good ideas on where we should be directing our advocacy on access to medicines, specifically COVID-related medicines, diagnostics, drugs, and vaccines. I just want to open the floor now to a question and answer session. Well, your questions can be directed to the presentations, but as well as thinking about ways in which we can use this report in order to inform advocacy. So you can either drop your questions in the chat, or raise a hand or unmute and speak. So does this mean we don't have any questions or even comments on the report? Okay, so the report will be available online, and the tracker will also be available on the FGPL website, and we'll communicate when the tracker becomes available. And then, so Catherine had mentioned some recommendations for CSO actions in her presentation, and Lauren highlighted some strengths and weaknesses. So I guess, are there any ideas about how maybe we can collaborate on those recommendations, or which are the most feasible or most pressing? The question is, when will the report be available? I think Annelien is better placed to speak to that. Yes, there we go. In the next 10 days. Okay, so if there are no questions and no comments, I think we can close the webinar here. Thank you all so much for attending. Thank you to Catherine and Lauren once again. Look forward to reading the final report. And once again, thanks to all the civil society organizations that contributed to this work. And thank you all for your time. Oh, Baone has a question. Please unmute. Or is that an applause? Okay.
No, actually, I was clapping my hands.
Okay, sorry.
Because as you didn't get any feedback, I just wanted to check whether you're in contact with TB Proof regarding the next actions, because that's an NPO focused on TB care, but also does work on intellectual property related matters. And we currently have a challenge with TB preventive therapy. It's not directly related to IP, but it is also where there's a new shorter regimen containing a drug called rifapentine. And the National Essential Medicines List Committee has not approved access yet on the essential medicines list, and one of the reasons they cite is cost. And this is again, it's a drug that can be made a lot cheaper locally, or one can negotiate with the producer to lower the cost substantially. So I did circulate this webinar's details to TB Proof. Please follow up with Ingrid Skuman about that. I'll post the email in the chat.
Thank you. Thanks for that. And we'll be in touch with them. Yeah, so I think we can end the webinar off there. Again, thank you all so much for attending, and hope you enjoy the rest of your day.